Hi everyone, good evening. How are you guys? I hope you all are doing good. Great. So I can see many names and the designations also here. I can see people are from academia, also professors, assistant professors, and people are from applied sciences. A lot of students joining today for this workshop. Amazing, amazing, amazing. Thank you guys. Thank you very much for joining. And I think let's not wait much. Let's start. So I'll invite Chetna to introduce our today's guest, and then we can go ahead. So let me tell about our guest a bit. So Dr. Pravallika is not just our guest, but she is my beloved sister and a good friend. And she has done her PharmD from JSS, and then she has done the oncology, her fellowship in oncology from JSS Mysore itself. Okay, and then she has worked in the academia for multiple years. And then today she is going to talk about the oncology, in the toxicology in oncology to all of us. So this workshop will go up to 1.5 hours to 2 hours. I hope you all will learn a lot from her because she is the expert of the subject. Okay, and you all have to learn and you all have to ask a lot of questions to her, guys. So please don't hesitate in asking the questions. Please ask a lot of questions and please learn a lot. And one more thing, stay till end. You have to fill the attendance form so your certificates can be created. Okay, guys. So over to Chetna, our intern. So that's all. Welcome, Pravallika. Thank you very much for accepting our invitation to deliver this wonderful masterclass on the subject, on your expertise. Yes, go ahead. You can open the mic, Chetna.
Good evening, sir. Good evening, ma'am. So, for our participants, let's introduce our guest again. Dr. Pravallika Buttukuru has an experience in college as assistant professor and hospital as oncology clinical pharmacist. She also have an additional experience in online teaching, hands-on training in chemotherapy for healthcare professionals and PharmD students. She has received Best Presentation Awards and provided guest lectures in various colleges. She holds a degree in PharmD and residency in oncology, which is a specialty in clinical pharmacy, which has equipped her with relevant skills and knowledge in understanding oncology pharmacotherapy. She was awarded with a Vasavi Union Charitable Trust Gold Medal in recognition of her achievements in academics. She has proficiency in chemotherapy dosing, administration, and monitoring, and expertise in medication reconciliation, identifying and resolving medication related problems such as drug interactions, treatment adherence issues, and medication errors to optimize patient outcomes. She is committed to ethical practice, patient confidentiality, and professional integrity while adhering to regulatory standards and institutional policies. Her experiences through implementation of various patient care practices as a clinical pharmacist have solidified her passion for this field when she observed treatment outcomes, enhanced quality of life through compassionate care for individuals battling cancer. So that's all from my side, ma'am. Over to you.
Thank you, Chaitanya. Thank you for the introduction. I'm happy to be back in this series of oncology. And thank you, brother. It's not just like our relationship is going from 2020. We have been started this oncology and we had a lot of gap in between continuing this series. Now we started again and I'm very happy to see 309 students here. So I think this number stays till the end. So that will be my achievement or target that in making you understand. And I hope this session takes you well or you learn something and you have some takeaways after the session. And thank you all. Be patient till the end. We'll start the class. Please do let me know if I'm clearly audible and my screen is visible and we can continue with the class.
It's perfectly fine, Pravallika. Go ahead.
Okay. Good evening, everyone. I'm happy to be here in front of 320 students live right now. And to start off, these recent days, when you keep hearing at least nearby your home, in around, in colleges, and different age groups, earlier diabetes, heart-related problems, cardiology-related problems were so much. But cancer was not heard of so much previously. But now, whenever you listen, you will be listening, okay, some of my neighbor, cousin, friend's mother, somebody is having cancer. It's become very common these days. It's all because of urbanization and because of lifestyle habits, and that influence in our uh, systems and body functions. And to tell you and to introduce you to cancer, cancer is not a single entity. It's a group of diseases. And understanding of the characteristics of cancer is very important to understand the principles and practices of cancer management. So, you know that normal cells grow, divide, and die in an orderly, predictable fashion. Whereas cancer cells show excessive growth, possess an extended lifespan, and also have metastatic potential that is not specific to an organ, but it keeps spreading throughout the body. Additional to various risk factors that induce DNA damage, which is the important step in cancer cell development. Recently, because of advances in genomic information, there have been significant progress in the understanding of genetic changes that led to the development of cancer. And also, it has provided us with insights of research for uh, discovering new therapies and new drugs. So there is abnormal growth of cancer cells. And you see that the major modalities of cancer treatment include surgery, radiation therapy, and drug therapy. Surgery and radiation specifically, they'll target the tumor, and cancer therapy medications will affect the whole body through various mechanisms of action. And these anti-cancer drugs include chemotherapy, targeted therapy, hormonal therapy, and immunotherapy. And these are often categorized as narrow therapeutic index drugs. And they are effective in targeting and destroying cancer cells, but can also cause a range of adverse effects on normal and healthy cells. And why are these toxicities? These toxicities arise due to drugs' mechanism of action, which often do not exclusively target cancer cells, but also affect rapidly dividing cells throughout the body. Especially chemotherapy, these drugs cause cytotoxicity of the cells. And for all the death of the cancer cells, cytotoxicity is not only the reason. There is some intracellular activity happening because of this anti-cancer drugs. That is disruption of signal transduction pathways that are involved in the proliferation, survival, and metastasis. And better understanding of these toxicities will help you in facilitating treatment decisions for cancer patients. As we move on, today's class, we'll be discussing general toxicities, grading, assessment, monitoring, and also general management of these toxicities. And we'll discuss few cases at the end of the session. And please be interactive during the session. I will keep asking you, please, you can post your doubts in the chat box, and we'll stop in between and have a discussion or at the end of the session. And don't disturb during the session. To your people, please put off your mics or unmute. Mute your mics. Unmute it when we take a break for questions. So, practically speaking, there is no anti-cancer agent that is devoid of toxicities. Okay? There is no anti-cancer agent that is devoid of toxicity. Please do remember, just not the anti-cancer agent. There is no drug with a side effect. That there is no drug that it is not having a side effect. And mainly anti-cancer drugs or narrow therapeutic index drugs, they will surely have toxicities. And when we see about chemotherapeutic drugs, So you have like older agents, like earlier, which were discovered early, they have toxicities like in a wider range when compared to the toxicities of the newly discovered drugs, because they used to act on cell cycle, and they also are not specific to a target. Now, because of these advances in technology and all, the genomic related causes of cancer have been discovered, and the new molecules have been developed with fewer adverse effects. And since all the cells of our body undergo cell cycle for cell division, and these anti-cancer drugs, they act on different phases of the cell cycle. Few of them act on all the phases, and few of them are phase specific alkaloids acting on the M phase. So the they're also rapidly proliferating and dividing cells. And in our body cells like GI, hair, nails, skin, all these are also rapidly and continuously dividing when compared to liver cells, renal cells, and all. Okay, liver cells also undergo division, but they undergo division only when required, that is during liver transplants and all. If liver keeps continuously going, you will lose your shape. So those are the cells, they're called as stable cells. And these skin cells, hair cells, these all are called as labile cells. And there's something called as permanent cells like neuronal cells and all. They don't divide. But once damaged, it can only be repaired within a specific period of time, but once damaged permanently, cannot come back. So that is the reason people who get stroke and even cardiac cells are also like, if the function is lost, it's lost. You can only preserve it, but you can slightly recover, but you cannot, that if the myocardial tissue is damaged, you cannot get it back. Okay, those are called as permanent cells. Since the cancer cells are continuously dividing in under cell cycle, and also the normal cells are also having similar function during the division, these anti-cancer drugs act not only on cancer cells, but they also act on different phases of the normal cell cycle of the normal cells. That is the reason you will see these toxicities with anti-cancer drugs. Okay. And earlier anti-cancer medications have more general mechanism of action. So because of that, it will narrow the therapeutic window even more. And so that even a small change in dose will cause you multiple and severe side effects. And these drugs are usually small molecules. They're around, 200 and 500 Daltons. And newer agents are like about 150 kilodaltons. And they're mostly proteins. So they target their site of action more specifically, and they carry fewer side effects. And they're mostly administered parenterally, and they have stark differences in pharmacokinetics when compared to the earlier small molecules with low molecular weight. And these molecules which were discovered early with small molecules with low molecular weight, they usually are metabolized to cytochrome P450 enzymes. And these larger molecules or newer molecules which are proteins, they're broken down into peptides and amino acids. And these larger molecules are relatively new, and also less studies have been there about their details. And points to know, rituximab is the first large molecule for cancer therapy that was discovered. It was indicated for non-Hodgkin's lymphoma, and later it was used for variety of cancers. So, and trastuzumab was come into the market as target for HER2 receptor and commonly expressed on breast cancer cells. And ipilimumab was a monoclonal antibody for metastatic melanoma, and pembrolizumab was also used for melanoma. So, and to ask me, when somebody asks me about the classification of these drugs, it's idiosyncratic, and also it should be analyzed for toxicity independently. Okay, so that is very important. Now we are seeing something called as non-specific versus targeted therapy drugs. That is what I was telling you. Non-specific anti-cancer drugs, see, they act on both malignant and normal cells. So the side effects which are commonly with these traditional anti-cancer drugs like methotrexate, 5-FU, cyclophosphamide, cisplatin, doxorubicin, irinotecan, mitoxantrone, vinblastine, paclitaxel, tamoxifen, and many other drugs. And the common side effects with these drugs are thrombocytopenia, neutropenia, GI-related issues, neurotoxicity, myelosuppression, secondary leukemias, peripheral neuropathy. And when you come to targeted specific anti-cancer drugs like imatinib, sorafenib, there's so many drugs, immunotherapy, targeted therapy, monoclonal antibodies like cetuximab. So there's so many drugs, and these go and kill the malignant cells. But very few normal cells are affected. It doesn't mean that a single cell is not affected, but comparatively very few when used with targeted specific drugs. And the common side effects will be like nausea, vomiting, skin toxicities. Skin toxicities you will not see much with the traditional anti-cancer drugs, but mostly you will be seeing this dry skin, congestive heart failure, hypertension, proteinuria. You will be seeing extra immune related reactions. So these are not these are like class specific. When you ask me like when you have different class of drugs, what are the common adverse effects with different class of drugs? Let us discuss. So you will see like, cyclophosphamide. It's an alkylating agent. The common is myelosuppression. And cisplatin, carboplatin, oxaliplatin, all these will have renal failure. Carboplatin is more hematologically toxic, and oxaliplatin will cause so much of peripheral neuropathies. And even doxorubicin also will cause peripheral neuropathy. And you see methotrexate, it will cause renal failure. And doxorubicin, dactinomycin, all the anthracyclines are known to cause cardiotoxicity. And doxorubicin in one major drug, means prototype drug, which is very commonly used. And dactinomycin C is also used, but the prototype is doxorubicin. These have something called as cumulative doses, a lifetime dosage that should be administered to patients. If you administer more of it, or if you administer or cross the limited doses, there will be toxicities in the patient, and you should not use more than the dose. Suppose if patient is given first time like AC regimen like doxorubicin, or it is also called as adriamycin, for the first time treatment to the patient, there's something called as lifetime dose. During the complete cycles of chemotherapy, if patient finishes his cumulative dose, next time when the cancer recurs or something, you should not use the same doxorubicin drug or any other anthracyclines. You have to check for if the patient have finished lifetime dose. You have to go for another combination of drugs for the patient. And vincristine. And these vinca alkaloids, they act on these microtubules. And these microtubules are important in nerve conduction and neurotransmission. And loss of this function will result in some of the toxicities with these agents. They have different toxicity profiles, like vinblastine and vinorelbine are morely associated with dose-limiting myelosuppression, whereas vincristine causes less bone marrow suppression, but it causes more neurotoxicity. And it used in some regimens like CHOP regimen and CVP regimen, which are used to treat lymphomas. And these side effects, they're sometimes reversible, but in some cases, neuropathy will persist. If the therapy should be discontinued when that adverse effects which are causing disability. And recently some liposomal formulation of vincristine was approved in the use of Philadelphia chromosome negative ALL patients. Okay. And fulvestrant, enzalutamide, these all are hormonal drugs. They cause fatigue, hot flashes, and all. And there's some HER2 blockers like trastuzumab and all. This trastuzumab, when combined with paclitaxel and use, it will cause more cardiomyopathies. And there will be decrease in left ventricular ejection fraction for the patient. That is the reason to give trastuzumab for a patient. They'll perform this echo test for to check the cardiac function. And then if the patient is above 50%, usually they consider 50 to 55. 50, at least 55 should be there, not less than 50 when you're starting with trastuzumab therapy, because it depends on practice also. Checking the comorbidities and all, they'll consider the function of the cardiac function of the patient before doing this trastuzumab therapy, because trastuzumab will have cardiomyopathy and it will cause decrease in LVEF. So they have to monitor patients' heart function when they're on trastuzumab, and the chance of causing cardiotoxicity with trastuzumab will increase when it is combined with paclitaxel in combination regimens. And something called as organ-specific toxicities. What is this organ-specific toxicity? There are some drugs which will cause organ toxicity specifically. So we have discussed about methotrexate. It is the prototype drug of this folic acid analogs. And then major adverse drug reactions will include acute renal failure. And also it will be increased when used in combination with cisplatin regimens, because cisplatin is a highly nephrotoxic drug which will cause renal issues. And with the use of these regimens, they always hydrate the patient after the administration of cisplatin to prevent this renal toxicities. So how it will cause toxicity is when used concomitantly, the renal impairing agents like cisplatin with methotrexate, it will delay its excretion and the levels in the blood will increase. That will also cause severe myelosuppression in a patient. And when we see about something, drugs like cyclophosphamide, it's a nitrogen mustard alkylating agent. It is also associated with neutropenia, anemia, and thrombocytopenia. And cisplatin have one more toxicity called as ototoxicity. So you have to monitor the patient for any hearing problems or anything issues, but we don't know the mechanism how it causes ototoxicity, but it is established. Some papers say it is because of dose-based relationship of cisplatin and ototoxicity. And cisplatin also has some black box warning for nausea and vomiting, which can be prevented with antiemetic regimen. So highly emetogenic chemotherapy is given to the patients who are on cisplatin to prevent the vomiting. And carboplatin is, cisplatin is highly nephrotoxic. Carboplatin is having highly hematologically toxic drug which will cause myelosuppression. Mainly thrombocytopenia, like granulocytopenia, anemia. Mainly you will see thrombocytopenia with this drug. And oxaliplatin of the same class, when it will also have renal toxicity and all, but it will have more peripheral neuropathy. And it is mild to moderate pain also will be there in the injection site for the patient. So, but what is the reason for the pain is not exactly clear or known. But why peripheral neuropathy occurs is due to the destruction of this neurons through binding of the drug to sensory neurons in the DNA. And when you see doxorubicin, which I have talked about anthracycline subclass, it will cause cardiomyopathy through generation of oxygen free radicals and lipid peroxidation in the myocardium. And moreover, it can produce
The
myelosuppression.
slides are not changing or changing?
No, this is this much. I'm just explaining.
Okay.
Yeah. In brief, I'm telling about the drugs. So doxorubicin can also produce damage through extravasation. So you have to be very cautious when you are administering you have to check for the rate and administration of drugs. And see, here we have discussed about androgen receptor antagonists and all these drugs. So these medications like enzalutamide, this enzalutamide, what it will do? It is mainly used in prostate cancer, and it is the androgen receptor antagonist. It will inhibit binding of testosterone and dihydrotestosterone, and it will produce some adverse effects like fatigue, muscular pain, and headache. Okay, and like selective estrogen receptors like tamoxifen. And this tamoxifen has a black box warning of uterine malignancy, stroke, and pulmonary embolism. And possible side effects are like hot flushes, vaginal discharge, and all these things. And there will be some blood clots also. So that is the reason with people who are on anticoagulants and all this, who have more chance of coagulability, they will be having contraindication of this drugs. And some drugs like trastuzumab we have discussed, and some when we discussed about dermatological toxicities, like panitumumab is one drug. Like you can see some dermatology. I told you like dermatological toxicities you will be seeing with some drugs like panitumumab. Like in the clinical trial, 89% of the patients had skin toxicities, and cetuximab also showed some toxicity with the patients. And cardiac toxicities you will be seeing with some anthracyclines, trastuzumab, and also some very famous drug called as imatinib that is used for CML, and it will cause congestive heart failure. And I told you SCRMs. So it will, with venous thromboembolism, it should not be given to patients. And bevacizumab also causes nephrotoxicity. So you should understand there are so many reasons for toxicities. Why are these various factors, that is causing toxicities? What is this non-selectivity in action? I have told you these drugs act on normal cells and also cancer cells and mainly rapidly dividing cells. So like bone marrow, GI tract, hair follicles, that will lead to toxicity. So they don't have see, generally they act on cells undergoing cell cycle and in all the phases. That is why you are seeing narrowing of your therapeutic index and also more adverse effects. Like, and DNA damage, some platinum compounds, alkylating agents, they all cause DNA damage, and they will lead to secondary malignancies. And what is this pharmacokinetic variations? How it will influence on toxicities, absorption, distribution, metabolism, and excretion. So there is variation in all these PK parameters, and which can influence the toxicity. This is because there may be dysfunction of the organs or age or multiple related factors that is causing altered pharmacokinetics in the patient. There's some patient-related factors like age, comorbidities, genetics, and nutritional status. Old patients with age, what happens is there will be decline in organ function. So decline in organ function, what it will lead to? It will lead to exacerbation of drug toxicities and comorbidities. How comorbidities will cause effect on toxicities, that you should know. So there will be so many liver abnormality, kidney abnormality. So if there is some abnormality, what it will happen? It will impair the drug metabolism. As we know that drugs are metabolized mainly through liver and also excreted through via renal route. And genetics. There'll be some genetic polymorphism in the metabolic enzymes. Because of that, there will be drug toxicities or elevation of levels in the blood, and there will be no excretion of the drug due to altered genetics or transporters. And nutritional status, see, when there is malnutrition in a patient, so there will be altered drug metabolism. So your GI is not proper, then what will happen? There is no proper, enzymes or something for the excretion or digestion, all this. So it will surely affect your altered kinetics. And then the patient will be susceptible to drug toxicities. And what are these drug-related factors? Drug-related factors like dose and schedule of the drug. So, there's something called as dose-dense chemotherapy. When you're giving weekly chemotherapy in patients, and also depending on the dose of the drug, if it is not uh, like certain dosing schedules and higher doses, they'll increase the risk of toxicity in patients. Like, sometimes continuous, like for example, continuous infusion versus bolus administration will have different toxicity profiles. When you see 5FU, all these, you will have bolus dose, you will have IV dose. Even for azacitidine, you will have subcutaneous administration and also IV administration. So here, the chance of adverse effects will change with respect to bolus administration and also IV administration, and also with continuous infusions. When during the continuous infusion of 5FU, for example, if the patient is not having PICC line or catheter for administration of the drug and it is being administered through peripheral IV lines, the chance of extravasation is high in patients. So like combination therapy, that's what I told you. When you are using methotrexate in combination with cisplatin, for example, you have more chance of renal toxicity. And formulations of the drug that I have told you that recently liposomal formulation of vincristine, and also there is some liposomal formulation of doxorubicin and also paclitaxel recently coming up in treatment of cancers. So liposomal formulation will have lesser side effects when compared to conventional formulation. And what are these tumor related effects? Maybe the tumor burden, and also tumor microenvironment. All this tumor burden is some large tumor burden, means there is so much of tumor inside your body. So when there is so much of tumor, some tumors, they rapidly proliferate and they'll have more of Ki-67 index or proliferative index in a patient. So that will cause more cancer cell burden in a patient. And because of that, when you give chemotherapy, there'll be so much of cancer cell kill. So when there is so much of cancer cell kill, what will happen? When there is so much of cancer cells, there'll be so much of lysis of these cancer cells. And so much of lysis of these cancer cells, they will cause so much of release of intracellular contents from the lysed cancer cells. So what it will happen, you will have so much of uric acid present in your body. So it may cause hyperuricemia. These mainly you will be seeing with leukemias where so much of cell kill happens. Okay, what is this immune system interaction? There's something called as immunosuppressive effects. These some anti-cancer drugs will suppress the immune system and it will increase the risk of infections in a patient. See, this you can tell. See, the most common, when you see about most common adverse effects of anti-cancer therapy, how I told you GI toxicity and all, there is so much of bone marrow toxicity also in patients. Bone marrow toxicity means it will influence on all the three cell lines like red blood cells, WBC, platelets, and all. Most commonly affected are WBC. And because they're also rapidly they're not dividing cells, but there's more and more production of blood cells from the precursor cells. There is no division in bone marrow cells. Here, whatever cells are there, it will die. So what will happen? Patient will have anemia, leukopenia, thrombocytopenia, and all this. So when there is leukopenia and when the bone marrow does not recover from first cycle to second cycle during the nadir period, what will happen? There will be increase in chance of infection because of immunosuppression. There is lack of WBC. There is no recovering of WBC. And there are some resistance mechanisms also. So cancer cells will develop some resistance mechanism, like efflux pumps. So leading to higher doses needed for efficacy. So you need to give more and more higher doses because of this efflux pumps. It will kick out the drug and there will be no action of the drug in the body. So you need to adjust doses and you have to choose alternative drugs and you have to implement supportive care measures in the patients. What are the other causes? There'll be so many errors in the medication use process. The prescription may be correct, okay, but what will happen? There may not be, maybe the clinical pharmacist who is preparing the drug is not preparing it properly. Maybe the diluent is not used properly. Maybe the dose is not injected properly. It's not always overdosing. It may be also underdosing in patients. Or everything, the preparation have been done by a clinical pharmacist with all proper care and techniques, but it have been administered after the expiry. Maybe there will be some drugs like azacitidine which have to be administered like immediately after opening the vial. Within 40 minutes, you have to finish reconstitution and administration of the drug to the patient. And sometimes, if azacitidine is given in subcutaneous form, and if the muscle is not good, and the person who is administering the drug do not have an expertise in administering through that route, then also adverse effects will happen. Sometimes, like vincristine is given through peripheral line and there is in a delay because of patient overload and patients there will be delay in connecting the flush of normal saline after administering vincristine. So there will not be a flush and drugs will get stick to the blood vessels and extravasation might happen and there might be some injection site reactions that may cause infection when it is not bothered or taken care of. And overdosing, I told you, sometimes, dose rounding and all may not be proper. Sometimes in subsequent cycles, when the weight is not checked for the patient, and in a hurry, if they will write the same dose as of previous cycle, and if the patient had weight loss for any reasons during chemotherapy or after the chemotherapy, then what will happen? There will be no, sorry. So what will happen? There will be no changing of the dose during second cycle and patient will be given same dose even after the weight loss. That will cause overdosing in a patient. So lack of training of staff in handling chemotherapy and because of drug interactions and lack of patient education. And St. John's wort when given with imatinib, suppose the patient is having some, for example, there was a case where in US, where in which the patient was carrying St. John's wort because she's a little bit depressed in her, and she get to meet a clinical pharmacist where she meets and she'll be discussing about imatinib and she'll be telling that she's not able to take the drug with water and she's need an alternative solution. If she can take it with juice or something, the tablet, she's feeling vomiting and nauseatic during the treatment and the medication adherence issues are there with her. So clinical pharmacist will be suggesting meanwhile she'll be seeing a St. John's wort in her hand. And when she sees, she asks her for whom that medication was, and she says it's for herself. Then what will happen? She will say there is a very significant interactions between St. John's wort and imatinib. So she will tell her what is the effect or problem taking St. John's wort with imatinib. They should not be taken together because there will be altered levels of imatinib and there will be no use of the drug taking for her cancer. So this is how a clinical pharmacist also plays a very important role in understanding drug interactions and also doing this medication history interview or doing medication reconciliation is very important in drug administration. Ankita, we will take a break in between. You can ask the doubts after 5 minutes. A lack of patient education. Patients are not properly educated while taking chemotherapy and also if they are not provided with complete information when they are diagnosed with cancer or started with chemotherapy and during subsequent cycles and there's no proper diet counseling and alternative suggestions for a patient when to visit the physician or when to call up the physician, all these things will cause adverse effects, and staff and patient ratio and lack of monitoring of chemotherapy. So monitoring and management of toxicities. So before we go, people who have any doubts? Somebody like, I'm not audible. Am I audible? One of you can tell me, reply me, am I audible? Okay, thank you. Okay, now we will be discussing about monitoring and management of toxicities. What is this monitoring and management of toxicities? Before you start chemotherapy, pre-treatment assessment is very important. That is nothing but baseline tests and biomarkers. So I told you chemotherapy will cause so much of myelosuppression, and monitoring for chemotherapy or starting of chemotherapy, you should have test for liver, renal function test, baseline hematological test, so that patient is fit for chemotherapy along with the performance status of the patient. And before starting therapy, biomarker testing with respect to certain cancer which is indicated is also very important to prevent the unwanted regimens to be administered to patients, like unnecessarily initiating the targeted therapy in patients in whom the biomarkers are not positive. And ongoing monitoring is, it's not just doing the baseline monitoring. For every cycle, you have to monitor blood test, imaging, and clinical monitoring. But when we call blood test, where do we do blood test? To give a patient chemotherapy, you need to check whether it is good neutrophil count or not. So you will see 1500 ANC minimum to start of therapy for a patient, and 15,000 to 1500 based on the drug characteristic and adverse effect profile, you will take a chance of risk of giving chemotherapy to the patients. And like for some specific drugs like which have chance of causing elevation in creatinine and all, you will monitor specifically liver function test and imaging for after giving 2-3 cycles, you want to see the progression of the tumor, whether your chemotherapy is working or not. If patients start complaining about some adverse effect, then you have to do imaging and clinical monitoring for symptoms. All this have to be done for the patient during every cycle or before every cycle to administer the drugs, and he should be discussed with all the adverse effect profiles and management strategies like dosage adjustment, supportive care, and symptomatic treatment. What is this dosage adjustments? For some examples like capecitabine, which is like a pox regimen, or capecitabine that is used in stomach cancers, they have so much of GI related effects. Already patient is having stomach cancer. In additionally, these regimens will have so much of adverse effects. So what will happen when they have so much adverse effects? You have to monitor the patient. So there will be some 1000 mg per meter square protocol for capecitabine tablets. So what they will do in Indian setting, most of the hospitals use 850 mg per meter square. Sometimes, if the patient is not fit and he's depending on his muscle mass and all, and patient is older age, even in other regimens, during the first cycle, they give only around 75% of the dose. And when you check the case sheets and all, you will be getting a doubt, why have they reduced? It is the suspecting a toxicity based on patient's performance status and comorbidities. They will give the patient only 75% of the dose of the drug, and then they will increase the dose during the second cycle if the patient is tolerating the first cycle, and it is purely physician based and physician's choice based on his expertise and experience and clinical parameters. And what is this supportive care? You know that cisplatin, when we have discussed, I told you it's a highly emetogenic chemotherapy. So highly emetogenic chemotherapy means it is having more chance of causing vomiting, and cisplatin has 100% chance if you check your incidence of causing nausea and vomiting. So what they will do, there will be something called as delayed vomiting. Vomiting may not be acute and immediate after the start of administration of cisplatin, but it can also occur after the administration of cisplatin. So what will happen? They will prescribe, because the patient will get discharged immediately after chemotherapy. Then what will happen? They will prescribe during the discharge some anti-emetic prophylaxis for the patient. And also some drugs will be prescribed which he have to start off even before taking the next cycle of chemotherapy, like olanzapine, which is used, like antipsychotic is used for one and as an emetic. There's so many drugs for highly emetogenic chemotherapy. This you can get the information from NCCN guidelines or when you refer chemotherapy-induced nausea and vomiting. And symptomatic treatment is you have to provide symptomatic treatment for the patient who face adverse effects. Mainly, you will go for non-pharmacological interventions as a part of general management to the patients. If not, then you go for drugs in treating these side effects or toxicities. So, I would like to tell you there is something called as grading of toxicities. What is this grading of toxicities? Like, okay, let me say, have you heard of the CTCAE grading of toxicities before? Yes or no? CTCAE grading? No, no, yes, no. Have you heard of severity scale when you have monitored adverse drug reactions? Okay. So you know something mild, moderate, severe, something you know about severity scale in adverse drug reaction. In the similar way, there is something called as CTCAE grading. What is this CTCAE grading? It is a standard classification and severity grading scale for adverse events in clinical trials and oncology settings. And it stands for Common Terminology Criteria for Adverse Events. And it is also called as Common Toxicity Criteria. See, in case of CTCAE, what is an adverse event? So, adverse event in clinical trials is anything that happens after the administration of the drug is taken as adverse event, and if it is related to the drug, it is called as an adverse effect. But when you are grading toxicities of anti-cancer drugs, here an adverse event is defined as any abnormal clinical finding that is temporarily associated with the use of cancer therapy. Okay, here causality is not required. So when you are giving cancer therapy to patients, that means it may not be immediate. So it may be during the course of therapy or even, after the course of therapy, for patients who are having immunotherapy. See, please note, there is a caution note here. See, who are receiving immunotherapy may present with treatment-related problems at any time during the treatment or up to 12 months afterwards, okay? For patients receiving immunotherapy, you have to consider additional prompts. Okay, I will show you the table. How do you do it? And this criteria is used for management of chemotherapy administration and dosing in clinical trials and to also provide, standardization and consistency in the definition of treatment-related toxicity. So this grading of toxicities, why are you doing with anti-cancer drugs is you want to give some symptomatic. See, I told you in monitoring of the chemotherapy, you have to give symptomatic management and also supportive care to the patients. To give supportive care, when to give supportive care, when not to give supportive care, what kind of supportive care you should prescribe to the patients. All that things you will discuss after checking what is the severity of toxicities. So this is how we will use. I'll show you something. What is this grading? So there is something called, see, some uses like grade 0, 1, 2, 3, 4, and 5th is always the death. It's not mentioned. And now the latest version is version 5 CTCAE use and CTA 6 is under process. Okay. So what is at grade 1? Grade 0 means you can continue with the treatment. Grade 1 means mild or asymptomatic adverse event. No interventions are indicated. See, like when I tell you, some of you, what you will tell, I have headache, but if I take a coffee, that is fine. I need not go for medication. So I have a mild headache. So one of you will come and comment, ma'am, I have severe headache. I need leave. I need to take tablet. I need to take rest. So that's how it is graded. But how you will even know which is grade 1, grade 2? That I'll tell you. Grade 2 is moderate adverse event. Minimal local or non-invasive intervention is indicated. See here, it's a minimal intervention and there is no invasive techniques performed in grade 2. And it also depends on type of adverse effect that is being intervened. Grade 3 is severe or significant, but it's not immediately life-threatening. Hospitalization or prolongation of hospitalization is indicated. Grade 4 is the patient is having life-threatening consequences. Urgent intervention is indicated. Something similar you would have seen in scaling of adverse events, in severity and all, ICU administration, organ is disabled, all this. So this is also similar to that. Grade 5 is death related to adverse event. See, see here is given as grade 0, grade 1, grade 2, grade 3 and grade 4 here. So these are the, see, for people or the patients for whomever the chemotherapy is given, there is something called as assessment for toxicities or patient assessment. So you have to assess the patient for all these things: chest pain, dyspnea or shortness of breath, diarrhea, constipation, urinary disorders, infections, nausea, vomiting, like mucositis, anorexia, pain, neuropathy. All these you will have to monitor for patients, like cognitive disturbance during the course of the chemotherapy. So, for example, we will take a simple one. Okay, suppose if you take we'll take you our favorite question, nausea. So when you want to see about nausea, how do you grade whether the patient is having grade 0 or grade 1, 2, 3, 4, which grade? So you have some certain questions to ask to the patient. So what are the kind of questions that you'll ask? You'll ask how many days you are having nausea, what is the oral intake the patient have, are they taking any antiemetic as prescribed or not? So such questions you will ask. Suppose if the patient says, I have nausea and vomiting too, then you should ask, how many days or how many episodes of vomiting? What is the oral intake? And along with vomiting, do you have constipation or diarrhea? All this you will have to ask. Suppose the patient is having mucositis. Then you have to ask from how many days? You do have any ulcers? Like, do you have any chance or like evidence of infection? Did you see any infection in your mouth? So are you able to eat or able to drink? If the patient is telling about anorexia, then you have to ask about any changes in weight loss. Is there any weight change? And for this patient, how is your appetite? And you have to consider some comorbid conditions, like you have to ask, do you have any hyperthyroid and recent weight loss? Sometimes these may not be associated with this. So you have to consider asking all these questions. And if see here for nausea, if it is grade 0, you can see, I have told you here before, grade 0 means you have to see this green color, you have to proceed with the treatment. If it is highlighted in this color, review by senior or nursing or medical staff. So if it is in red color, it should be reviewed by the senior and staff prior to treatment. You should not have to start chemotherapy if patient has such grade of toxicities. In case of chest pain, even in case of fever is normal, then you can continue the treatment. So if the patient is having anything temperature between 37.5 or above or below 36, then you have to get assess the reason for fever. If there is any chance of infection, why the patient is having fever. And in fever, you should not give any chemotherapy to the patient. So a medical review is required. And chest pain, so urgent assessment is required. And in case of diarrhea, see here, increase in of less than 4 stools per day over patient's baseline, mild increase in ostomy output compared to baseline. So when it is grade 2, grade 3, grade 4. So you have to assess all these in a patient when he comes to take chemotherapy prior to the administration of chemotherapy during subsequent cycles. And you have to treat these symptoms in a patient and then check for the risk of further exacerbation of these symptoms prior administration to chemotherapy. Okay, this is all for, like, you have different criteria or different definition for different symptoms in a patient. Okay, and when we see like neuropathy and all, so this is all you will be comparing from the baseline. Okay, like whether a patient have neuropathy, all these things you will compare it from the baseline and check it. And like confusion, cognitive disturbances, all this you will have to check. See, when you find it in the internet, you will find it like National Cancer Institute CTCAE version 5. So you will have previous versions also, but latest the definitions and the latest practice or grading of these toxicities is done based on version 5. Severe nausea and vomiting, loss of appetite without alteration in eating habits. So when you ask questions, patient will tell, so I'm eating fine, but I still have appetite loss. Some will tell, like, I have decreased oral intake, but I don't have weight loss. The patient has dehydration or malnutrition. Then you will grade the patient as grade 2. It is all depending on the what information patient is giving, you will grade the toxicities. And it will be defined. See, nausea is characterized with queasy sensation or the urge to vomit. So everywhere it is given a definition depending on the complaint of the patient, that you have to go and check what kind of adverse event it is and what kind of grades. Why you need this grading of toxicities? To provide treatment for the patient. See, your intervention is not indicated when it is grade 1. It will subside by itself. You can give non-pharmacological interventions to a patient. So, and you are also already having prophylactic medications in his treatment chart or in his discharge medications. So there you will tell if the patient have so and so symptoms, the patient will be counseled to take the medications. If not, they will not suggest. So grading is mainly to take decisions on symptomatic management of the anti-cancer toxicities. So for mucositis, please do see this asymptomatic or mild symptoms. Intervention is maybe some redness or something is there, but still oral intake, everything is proper. Then you'll ask them to apply some gel or, flush the mouth properly, clean the mouth properly, take the salt water gargling and all these things. And you should not use so much of salt and oil kind of and spicy foods for patients who are having that oral cancers and also, mainly head and neck cancers where this throat and digestive tract are involved, to prevent the further adverse effects or further damage of the gastrointestinal tract. And ulcers and all may cause pain. Then it, moderate pain, and that does not interfere with oral intake, modified diet indicated. You have to prefer giving alkaline foods to patients compared to acidic foods. And also you should ask about gastric related issues in a patient. So fatigue, rash, bleeding, bruising, ocular related problems. Extravasation also mainly for the drug which are having extravasation. When patient will complain of any extravasation or infection at the site of injection, you have to ask patient some questions like whether there are any problems during or after the administration of the treatment for the patient. When did that problem start? And is the problem around or along the injection site? Does the patient have a central line in place? Describe the problem. So you have to ask, still it is itching, there is redness, there is some infection, is there any swelling? All that you will have to observe and give treatment for extravasation for a patient, because it may take to an extent that you will have to remove the hand also because of infection and extravasation. See, this is one of the patient's hand-foot syndrome that have been seen with the regimen of Capox for this stomach cancer. See his hands and foot. It's completely become dark. Nails, foot, hands, everything is become dark in this patient. And I told you that some toxicities are irreversible and some are reversible. These darkness will not be so much, or it will completely subside in patients after the entire chemotherapy when the patient stop getting chemotherapy with these drugs. Sometimes it will become light. It will not be so thick as it is. And you see the dry skin also in the patient. So this is one hand-foot syndrome example. And this hand-foot syndrome is also called as palmar plantar erythrodysplasia. So when patient is diagnosed with such, you have to ask him how long, whether the patient is otherwise well, or any other symptoms along with this, like stomatitis and diarrhea, all this. Like these are, if patient is on active sunitinib and also, capecitabine, all this. So if it is so severe that patient is not uh, able to tolerate these adverse effects, you will have to stop the treatment with this and you have to choose other regimens. So when we talk about general management of toxicities, like I told you, anemia. What is this anemia? It's nothing but low red blood cell count is in the production of, in the bone marrow production. So you are having low RBC, means your bone marrow is suppressed. It is not able to produce RBC. It is not able to recover. So what you have to do for such patients that you think, see, these all not to be told, always the prevention is better than cure. Always counsel a patient even the prior to chemotherapy. If you know that the drug is having a chance of having anemia, encourage the patient to rest between the activities, eat foods that are high in protein and iron, administer like erythropoietin stimulating agents. If the patient may have the risk of thromboembolism, you will have to evaluate all this. And patient like appetite changes. So, and this will be mostly seen with people with gastric cancers and oral cancers. All this sometimes, this may be due to, patient after radiation also there'll be so much effect. Head and neck cancers, the most common treatment is combination therapy of radiation along with chemotherapy. So such patients you will be seeing more chance of having mouth and throat sores. There'll be change in sense of taste or smell. There'll be more chance of nausea and vomiting. Then you have to advise patient to have adequate hydration, eat healthy nutrient diet, exercise regularly, treat this oropharyngeal sores, and provide adequate mouth care should be suggested to the patients. And bleeding and bruising. See, when you are suggesting for cancer patients prior to the therapies, when you know that there is chance of bleeding, you have to tell them, gently brush the teeth. Do not hold or any knives, or do not drive also, because there is chance of holding it tight and there's chance of bleeding if you get touched to any sharp objects and all. And electric shaving, avoiding razors, all this you will have to tell to the patient if there is chance of bleeding and bruising. And mainly for people who are on anticoagulants, you have to clearly mention and counsel the patients. And when you talk about constipation, you know that constipation is a major issue with most of the drugs, and also some painkillers like tramadol, you will see so much of constipation. And for tramadol is given very commonly in patients with cancer, because cancer pain management is very important during the administration of chemotherapy. See, that is what opioids, changes in diet. So you have to encourage them having, I told you, alkaline foods. Alkaline foods means something like, bottle guard types of food, pumpkin, bottle guard, all these foods. And also increase fluid intake. You have to avoid tomato and some root, aloo, radish, all this which will cause gastric issues. And you have to take so much of leafy vegetables. See, always remember, I'll tell you one small concept. Many people will ask a clinical pharmacist, they're very healthy. Some people who are non-vegetarians, they go for asking some questions like, can we have non-veg? Can we have egg? Can we have this mutton soup, chicken soup? Yeah, doctors also will tell you, you can have all this. But always prefer having easily digestible vegetarian food. You remember why? Because if you're already people who are having cancer-related chemotherapy or treatments, there'll be so much of fatigue and extreme tiredness in patients. May not be during first cycle. Most of them sometimes people will be able to handle. Some may not be able to handle cancer fatigue, cancer-related pain. All these are very common adverse effects that the patient will face during this treatment period. So when you take easily digestible foods, so whatever energy the patient is taking, little is enough for digestion. And so the remaining energy will be available to the body for cellular repair and for function of the immune system. So even for normal people, it's easy, it's very good if you take, and digestive issues are very common, as I told you, with anti-cancer drugs. So do not hurt or trouble your digestive system during the therapy. And taking high amount of fiber foods, what will happen? It will ease digestion and slow absorption. And if glycemic index of the foods is less, then what will happen? There'll be slow absorption and you'll get continuous energy in your body, and high fiber foods will cause good digestion and good fluid intake. So you may not be able to take the fluid directly as water. Try to suggest in the form of buttermilk or vegetable soups, or in the form of soups even if you want to take non-veg and all. And dehydration, because lack of sufficient hydration. Diarrhea, nausea, vomiting, all this will cause dehydration. So for that, what you have to suggest to the patient? IV administration is considered when the patient has severe nausea and vomiting. And edema. So, some drugs like docetaxel, they'll cause so much of facial edema and fluid edema, and you'll have some pitting edema on foot, and facial edema also will be there. So, when lack of proteins in your body also will cause edema. So, the fluid will ooze out. So, you have to tell them what kind of clothing you have to do. You have to do exercise. Exercise doesn't mean doing gym and very big exercises and weightlifting exercise. It's a normal exercise, normal walking, and simple exercises, whatever is possible to the patients. And you have to administer diuretics if there is severe swelling. Fatigue, it may be due to anemia. And maybe if the patient won't have proper sleep or sleeping difficulties. So you have to tell them to rest between activities and do not stand in one place, and also do not continuously work. All these you will have to talk to the patients. See, this is one pedal edema that have occurred to a patient with administration of docetaxel. And some drugs like docetaxel, they have severe bone marrow suppression also. So for some time, how I told you, prevention is better than cure. Not only telling them how to take care at home or general management, they also give some colony stimulating factors which will stimulate the bone marrow for the production of the cell lines through precursor cells. So flu-like symptoms. Sometimes after the chemo, you have some flu-like symptoms. It may be for 2 to 3 days. So you will have to tell the patient to increase the protein intake and also treat the diarrhea and like manage nausea and vomiting. For nausea and vomiting, you will see that you will be giving anyhow prophylactic and symptomatic management in the discharge medication. And hair loss will be there with chemotherapy medications, because they are also continuously dividing cells. So what will happen is, that is the reason most of them shave it before the starting of the chemotherapy. You have to ask them how to use clips, mild shampoos, sunscreen for the face. But remember that it will grow back. A patient will lose eyebrows, everything. Aesthetics is very important. Many people have caution towards their aesthetics. So you have to tell them to buy caps, shawls, and some cooling devices. All these you will have to suggest them, educate them, and encourage them to take chemotherapy irrespective of adverse effects and the severity of adverse effects. So hepatotoxicity, like how I told you, these are not the toxicities that you will see immediately in patients. So like with prolonged treatment, you will find changes in hepatotoxicity, like maybe impairment in metabolism or some hepatotoxic drugs. like in renal function, when you say about renal toxicity, you will be seeing like sometimes elevation of serum creatinine level, like how I told you, when you're giving cisplatin and when you don't give enough hydration to a patient, drug may not be excreted completely from the body, and there may be elevation of the serum concentration levels and causing renal toxicity there. So if it is severe hepatotoxicity, you will see dosage adjustments of drugs according to protocols, and this all will be there for the drug characteristics when you check for the drug information for the specific anti-cancer drugs, and during subsequent cycles when you monitor liver parameters, you will have to change the dose of the patients or do dose modification, which I told you one of the techniques, or one of the ways to monitor treatments. And infection, I told you, it's because of the blood cell counts. So neutropenia mainly 10 to 14 days is the nadir period for most of the drugs. What is this nadir period? Nadir period is nothing but where you will see the maximum toxicity with the drug, or the maximum fall in decline in the blood counts. See, for most of the drug, after the administration, day one, if you give chemotherapy, and when you check the blood counts for the patient between 10 to 14 days, you will see the maximum drop in the blood counts. And from 14 to 21st day, it starts increasing. It is not increasing means your bone marrow is suppressing. Suppose from 8,000 it has come to 6,000 after the first cycle, and after second cycle it has come to 4,000, but there is no recovery when you check the blood test for a patient before the administration of chemotherapy. I mean, you should be cautious that it may be normal level even after second cycle, but you see the trend in values of WBC, means it is decreasing. Bone marrow is not recovering. It means the patient's bone marrow is being affected with chemotherapy. So you have to be very cautious, and you have to educate the patient about leukopenia and chances of infection, and you have to counsel accordingly. Memory and concentration changes, and you have to advise them to take brain puzzles and all this, and use some like reminders, planners, smartphone applications, all this. Mouth and throat related problems, you have to ask them for go for a dental checkup and oral hygiene maintenance, check for sores, all these things. And lidocaine and some antacids, topical diphenhydramine, all these to relieve the symptoms you will have to suggest. And low platelet counts, there'll be chance of bruising and bleeding we spoke about. And myalgias also will be very common with these taxanes. Docetaxel, paclitaxel, you will see all this, gabapentin, antihistamines, and NSAIDs will be giving to relieve the pain. Nausea, vomiting, I told you. And last be telling some vitamin C tablets to avoid spicy food, sweets, all this, avoid strong odors and all the smell. Some people with caffeine, they also have nausea and vomiting. So you always tell them to avoid all that. And peripheral neuropathy, I told you, you have to examine for patient assessment you have to do after every chemotherapy, and you have to administer or you have to prescribe medications accordingly. Just peripheral neuropathy, you have to not to think when patient complains of peripheral neuropathy. Once again, you have to not to think it's only just because of the drug. You have to see whether the patient have any vitamin B12 deficiency, or you have to see any other causes that would have caused peripheral neuropathy before treating or providing symptomatic management or supportive management to the patient. And pulmonary toxicity, you will be seeing mainly with busulfan, all these drugs. And you will see with trastuzumab also, patient will have infusion related pulmonary toxicity. So assure patient have resolved after the treatment is administered, and prescribe oxygen therapy, glucocorticoids in severe cases, or else you have to tell them, just you have to monitor for pulmonary toxicity and immunosuppression in patients with multiple comorbidities. And sexual health and all, chemo will lower this testosterone levels and libido in men. And also, like, you have to check the semen after the treatment. See, before, if they want to go for conceiving and all, if the male has some sexual and fertility issues, that all will be counseled by a uh, physicians. So it depends on treatments. Some they'll be able to give their, some will do sperm banking and all. before going to treatments if they want to have a child or something. All these are sensitive issues that will be discussed not by the clinical pharmacist here. As of now, it will be discussed with the family and also the couples through doctors. So medications and procedures available to treat erectile dysfunction, fertility, preserve like sperm banking and all, to use condoms and refer patient support programs will be there, and they'll be referred to those people for counseling. And in women, you have to discuss about intercourse, vaginal gens, use of lubricants, fertility preservation options of embryo cryopreservation and eggs. And also you have to educate patients about pelvic muscle exercises and also, non-estrogen treatments. You have to prescribe to patients because there will be chemotherapy will stop ovaries from releasing eggs and estrogen. And also you have to counsel if the patient is pregnant, they cannot proceed with pregnancy and chemotherapy. So all these needs to be considered, and patient support programs will be there where they'll be sent or referred for counseling. Skin and nail changes are very common with chemotherapy. I've shown you the patient with capecitabine or capox regimen who is having skin changes, and nail discoloration of nails also will be there. And nails will become, easily breakable and all that. So you have to, like dry skin, itchy skin, you should tell them to apply some moisturizers. All this, avoid alcohol or perfumes, apply lotion after bathing. You should avoid hot water. For some oxaliplatin induced nephropathies and all, you should avoid cold water. The patient should not wash himself with cold. So that will exacerbate the peripheral neuropathy when oxaliplatin is given. And always use sunscreen when outdoors. And also keep your nails trimmed, anti-itching medications. Like usually you don't give medications also, you tell them to have coconut oil applied on their hands. So you can see some skin and nail changes in the patient. So bladder problems and all, you have to monitor for UTI infections like pain, but because there will be no consumption of good amount of water because of nausea and vomiting, there will be more chance of urinary infections. And sometimes, there will be the drugs like doxorubicin may cause red color urine because the color of the drug comes for urine, and they may be thinking that it might be blood, not the drug or the urine. So you have to counsel the patients for all that. And you have to advise the patients to drink good amount of water, and you have to monitor weight loss. Weight loss is mainly seen with poor appetite, and also with the administration of a treatment along with combination therapy like radiation to treat head and neck cancers. So for some patients, you have to give fluid intake. Usually what we do is, when I used to practice in patients, I used to tell, taking coconut water and all is not suggestible because it may cause cold or something. So if they're taking, that is fine. Excuse me. So, and that taking so much of fiber is also impossible for the patient during his treatment course. So when some patients complains of, that he is not able to have adequate amount of hydration, some people will tell it's a cold place, we cannot have buttermilk. But having in the form of water, severe hydration is very difficult for any patients. So what they used to do when they used to come with such complaints of loss of appetite and loss of energy, what I used to tell them is to have some vegetables like, bottle gourd, tomato, carrot, so much of jeera, all this, curry leaves, all this, put it in a cooker, and then, they can have boil it in water, and then you can take it like a soup, adding some salt and pepper, and you can consume throughout the day, hot, so that it's having some flavor, so much of antioxidants will go into the blood. So you are consuming more amount, and it's also good for digestion when you take it in the form of soup. Sometimes you cannot chew, and because of cancers, this will be a very helpful. And I have seen so much of result, people coming and complaining they are happy after that, and they're having good hydration, and also help them, with good, they have some energy levels, they feel some active, they're not feeling so tired. It's not just having some carbohydrate liquid or, like sambar every time with only two pieces, but this is giving them some additional benefit because it will take good amounts of nutrients also, and absorption also will be very good. Okay. And see administration. See here is something called as three-way administration technique. See, that's what I told you. And there is vincristine is a drug which is having so much of extravasation in a patient. So you want to prevent extravasation. What is something called as three-way that is connected to the cannula from one. See, there is one tube here which I am showing that is connected to 100 ml NS. So that is the flush which have to be given after the administration of vincristine. So what we have done is we have started putting on normal saline first, and we used to allow running of 10 ml or 20 ml NS and ask patient whether at the site of this cannula insertion whether they have any itching or they are fine. When they tell they are fine and no itching, it means that the IV line is clear. It's inserted properly, and you see something here, some white color one. Why they have kept it? It's called a slint. So they tie a slint to the hand so that there will be no movement of the cannula that is being inserted here. So there is no chance of drug moving here and there, even the patient will move hand. So we used to start with NS and slowly mix this drug in amount 2 to 3 ml NS and inject it slowly for 3 to 5 minutes into the running NS. So the drug is going to the running NS. So there is no chance that patient will have extravasation. And after that, this will be off. This port will be off, and from this side continuously NS will be moving and patient will not have any extravasation. So after using this technique, I think single patient did not have any extravasation till now. And it's one new technique that we started like placing a stent and this to avoid extravasation. When previously we used to have at least one extravasation once in a while. So now it's been prevented. And another technique is, if you ask me, ma'am, can we this extravasation, how it is prevented? In most of the hospitals, PICC line is the peripherally inserted central catheter, wherein which throughout the chemotherapy, they just need to flush and clean the PICC line. And there is no every time insertion or puncture of this peripheral lines or puncture of your blood vessels to administer chemotherapy. It's like a port. So now we'll go for case discussion. See, for example, the patient is a 54-year-old male who is a known case of type 2 diabetes, who is presented to the hospital with complaints of ulcer over the hard palate since 2 months. After CT and biopsy, it was confirmed as carcinoma of hard palate, and the patient was planned for weekly concurrent cisplatin chemotherapy. So I told you most of the head and neck cancers are treated with radiation and chemotherapy. Here, what is that? Patient will be given with 5 days of radiation, and among that 1 day you will have chemotherapy. So here the patient's BSA is calculated and the drug is given. See here, I told you cisplatin is a highly nephrotoxic drug that you can see here. See IVF into 2 pins IVF, 500 ml NS plus KCl and 2 cc NGS4 is given for 1.5 hours after the administration of cisplatin. This is to prevent nephrotoxicity and electrolyte imbalance with the drug. And see, you see Dexona, ranitidine, all this is given with cisplatin. Granisetron is an antiemetic. Okay. And dapaphage is that is anti-diabetic medication that is given. Candid mouth paint for local application. I told you, because it is hard palate, already cancer is there. There is chance of infection over there. So they have given as a prophylaxis. See here, the symptom management prophylaxis is prescribed in the discharge. And Oleans is olanzapine. I told you, antipsychotic that is given as an antiemetic that you can see, and betadine mouthwash. I told you oral hygiene maintenance is very important. But here you have not seen any medication, but you have seen only prophylaxis and a local application, candid mouth pain to prevent any infection. And MST is also antiemetic if required. If required means if you have any vomiting, you will have to take it. Dexamethasone, corticosteroid also vomiting. And Digene is for digestion to prevent constipation. Tramadol is for pain. I told you tramadol is very commonly used. Pain, killer and ranitidine and Dufalac. This is for Dufelac is for preventing constipation, and ranitidine is for preventing acidity, because that treatment will cause so much of acidity in patients. So this is like advice on discharge. So patient have to be counseled. So when cycle 2, when the patient comes, so the first treatment was given on 17th. Patient came on 23rd because it is a weekly chemotherapy. Every week it is given treatment, 5 days radiation, and in that 1 day chemotherapy, and 2 days you will give off, because that is called as radiation free days. It is given to for the normal cells to recover from the effect of radiation. So they are called as radiation free days. Again, the patient complains of burning sensation and difficulty in swallowing from 19th. That is after 2 days of chemotherapy, he started observing changes in his mouth. He told that he is observed a white patch, and he's had difficulty in swallowing. And patient also complains of burning sensation. So, and he complains, when he complained at this, and the physician oral examined the patient, and he found a white patch, and it was diagnosed as oral candidiasis. See, during the first time, he had 68 kg, and because of this burning sensation and difficulty in swallowing, patient had loss of appetite. And because of loss of appetite and no proper intake of food, patient has decrease in weight, 65 kgs. So 3 kgs he was reduced. And when the patient came, he was prescribed with fluconazole 150 mg once in a day. And then the blood tests were done, and then second cycle of chemotherapy was given to the patient. Okay, this is one case study, and this one I'll tell you, ma'am, how did you understand why that you should prescribe a treatment, when you should prescribe a treatment for the patient? See, you have seen here, for example, like oral mucositis. See, moderate pain or ulcer does not interfere, severe pain interfering with oral intake. So the patient had burning sensation, and they found a white patch, that is ulcer. And it is also interfering with oral intake. So it is around grade 2 to grade 3. So that is where treatment is prescribed to the patient. So you have any questions? So I can tell you some more examples. May not be here, some cases I will tell you. So when you are giving some, I have told you about the recent like skin reactions, that so many anti-cancer drugs have skin reactions and all, immunological reactions and all. Immunological reactions, mainly you will be seeing with the drugs that are like newly, like trastuzumab, rituximab, all this patient will have hypersensitivity, like decrease in blood pressure, all this during the first cycle of chemotherapy, and they're very common with this. And cetuximab, we also have, like cardiopulmonary arrest also will happen in some drugs like that. So you use some technique called as desensitization technique in patients to prevent this hypersensitivity reactions. So immediately patients will start reacting, and a full redness in the cheeks. All will happen immediately after one drop of chemotherapy enters their bloodstream. And due to incompatibilities also, when oxaliplatin is when the proper reconstituting fluid is not when the drug preparation is not happened properly, all this, it will cause chelation and sometimes death of the patients. And sometimes incompatible, like if you are using some plastic bottles of NS, when you are administering the drug, like for example, paclitaxel, it is not compatible with that because there will be some reaction of this PVC. So that will cause chelation and also hypersensitivity reactions in patients. And there's some diluent called as gramophore in paclitaxel. Not only that causes hypersensitivity reaction, but this reaction with the compatibility also causes hypersensitivity reactions in patients. And they are managed by giving hydrocortisone and heavily injection prior to the administration. And again, if still it happens, they will give some oxygen to the patient and also stop the chemotherapy for a while, and they'll start with a slow rate of infusion. If it is going fine, then they will continue, or if not, they will stop the drug. So you people have any questions? And thank you. I've seen the same number till the end of this session. Any questions? You can unmute your mics. You can ask me. Yes, Pushpanjali Panda, you have asked me one question. Is there any precautions to be taken while administering immunotherapy? That is what I am telling you. When you're starting any immunotherapy treatments that I told you, most of the adverse effects are undiscovered. And because this immunotherapy is also targeted therapy, and this immunotherapy, you will be giving patients might have any chance of any toxicities. So always you start with a different protocol for immunotherapy drugs. Because you are stimulating your immune system. And for targeted therapy drugs, when you're giving rituximab and all, I told you usually you pre-medicate a patient always 20 minutes prior to the therapy. But here, you give antiemetics and all 20 minutes prior. Some drugs like hydrocortisone and all these, like Evil and all, diphenhydramine hydrochloride, all these drugs which are used to give, you will give it just before starting of the drug, and you will start at a very slow rate. And the first little dose, you will dilute it so much, and you will not give the same concentration as you give it for the protocol. Okay. And any doubts? We use this scale in CTCAE therapy for highly or moderate emetogenic weights. We are using our project, which is in onco. We also use CTCAE. Okay, fine. We use this scale in CTCAE therapy for highly or moderate emetogenic. See, how there is something called as when you are giving chemotherapy to patients. Okay, I'll tell you. Suppose when you're giving interleukins and all, you will give some acetaminophen, paracetamol 650 mg prior to each dose, and some NSAIDs. And for some drugs like ibrutinib, all these you will give diphenhydramine per oral and acetaminophen 30 minutes prior. And for like docetaxel, you'll give dexamethasone, all these drugs, corticosteroids and all. For some drugs, you will not give any pre-medications like panitumab and all. You will not give any pre-medications. That is not required. But CINV, where do you prefer drugs? See, when you want to add on any emetogenic, prevent this emetogenicity in patients, what you will do is, you will check there is some class of drugs, highly emetogenic chemotherapy means, which have more chance of causing vomiting during or after administration of chemotherapy. For such drugs, you will go and check the guidelines, and they will give you what are the 3-drug combination, 4-drug combination regimens to be prescribed along with that chemotherapy for a patient. So you will do it that way. So So somebody is asking 2 more cases. See, I can tell you one more example. When you start administering paclitaxel during the first cycle, how I told you rituximab, paclitaxel, they cause hypersensitivity reactions. Some patients will start complaining about, having tiredness, fatigue after 2 days after chemotherapy. Some will have acute vomiting. Okay. During cisplatin administration, because psychological impact also will be there with the patient. Management of extravasation I have showed you, and extravasation management will be, there is something called as wave. Wave means warm pack for Vinca alkaloids. For other extravasation related drugs, you will have cold compress. Warm compress for Vinca alkaloid related extravasation, and also antibiotics depending upon the severity of extravasation you will prescribe to the patient. Somebody is asking, yes, you are eligible to give non-pharmacological counseling to the patient, but not by yourself. You will have to approach your teachers before providing that. I did this when I am working as a clinical pharmacist in the hospital. But when students wanted to counsel, they used to come and discuss with me the case. And then we used to intervene the case, and they used to tell me what kind of non-pharmacological intervention they want to suggest. And I used to correct them, and then they used to go ahead with that. So see, always adjuvants along with the active ingredients are to increase the miscibility of the drug in the liquid. So you want to give the drug, you have to make a formulation. Is the API should dissolve in that liquid. That is why you will have it as like cremophore is used as a diluent. So olanzapine actually used to give it like antipsychotic. How it works as an antiemetic regimen is, I told you, psychologically also patient will have, see, everybody have this traditional thinking that you will have vomiting when you take chemotherapy and all this. And when they started using this olanzapine, it started working. And they have done some trials and all. And then they are using it as, see, the dose will be different when used in psychiatric conditions and vomiting, but the mechanism of action will not change. Yes, I have seen Poonam immune-related reaction. That cetuximab, even I have faced a challenge of, that the patient has been advised for a code blue also. It has been so severe reaction. They discontinued the drug during the first cycle. Okay, you have any other doubts? CAR T-cell therapy still should be available. It's not affordable. You see, current treatment protocols, it's not current treatment protocols. It is like based on the, that need for the patient and need in the treatment, and also availability and cost. It's not available for everyone. Most of the treatments taken are as, under government schemes. So that does not provide, and everybody will not be able to afford for it. So you have any other doubts? See, can antiplatelet be given along with anti-cancer drugs? If patient has, now patient had, that's what I told you. Always chemotherapy is not intention of curation. It may be palliation in patients. I told you cardiac function of the patient should be assessed even to start chemotherapy. That is nothing but the performance status. So after analyzing that only, first of all, they will choose to give anti-cancer drugs to the patients or chemotherapy, irrespective of whether you add antiplatelet agent or not. So any other doubts? See, even immunotherapy toxicity grading, everything is this grade 1 to grade 5. You have to just see the name of the toxicity and see that what is there under each. See, when you will stop chemotherapy and radiation therapies after the prescribed treatment is over. So every cancer and every stage have that prescribed cycles to be given based on the stage that has been mentioned for the patient. So you will stop it like that. Sometimes if severity of adverse effects. It's not, it remains in the body, but if you further use the drug again, there is cardiotoxicity with anthracyclines. No, spirulina is not used as any anti-cancer medication. These are all the adjuvants of, adjuvant therapies, that you will give to really decrease the side effects. So I think all the doubts are clear. If anybody want to ask, then unmute your mics and ask. Just want to know, like, would you like to have more classes, some related oncology topics, and how did you feel about the session? Was it informative? Did you all learn something? I am also very happy that you all stayed till the end.